Hello, my name is Michael Day. This is a PowerPoint presentation regarding mechanical ventilation. Hope you enjoy it. This is what a typical patient in ICU looks like. You have your mechanical ventilator, your heated humidifier below that, inspiratory and expiratory limbs going to the patient's endotracheal tube. The endotracheal tube goes into the airway to ventilate the lungs with the volume of air. It's cuffed at the end so that whatever your volume you would desire to give that you plug into the ventilator actually goes into the lungs so you can control the respiration. This slide is the anatomy and physiology of the upper respiratory tract. Kind of looking at this from the intubation standpoint. If you use a curved blade, which is a Macintosh blade, you want to identify the epiglottis, which is labeled in blue, and the pink just above that notch, that is the vallecula. You want to insert that blade into the vallecula and lift up and towards the toes, and that provides a direct view by pulling the epiglottis up. If you use a Miller blade or a straight blade, you want to actually identify the epiglottis and lift it up directly. The other approach in the vallecula is an indirect lifting, but both should expose to the vocal cords. The vocal cords will appear white, and you should also be able to identify the more pink esophagus opening. So usually you can see the esophagus first, and as you lift up, then the vocal cords will come into view, and that's where you do the direct visual intubation. This is the slide of the Puritan Bennett H40 ventilator. This is what's commonly used at TriHealth in the intensive care unit. It's made by Covidien and has all the various modes we're getting ready to talk about. This ventilator is the Viasys LTV. This is what PTS services use, and it has many of the modes we're getting ready to discuss also. This slide describes the most common modes of ventilation used. We have the assist control mode, SIMV, which is synchronized intermittent mandatory ventilation, pressure support, or PSV, CPAP. We have BiPAP, which is non-invasive, and we have bilevel, which is an invasive form on that 840 ventilator. We have modes of ventilation. We also have types of ventilation. There's volume control ventilation, where you are setting the volume that you want the patient to receive. There's pressure control ventilation, which is where you set a preset pressure, but it does not guarantee any volumes. There's a spontaneous mode where the patient can breathe pretty much like they're not even intubated, and we augment that with pressure support. And pressure support is basically dialed in to overcome the work of breathing through endotracheal tube, which is a bit smaller than the normal size airway, so it overcomes that effort. The best way I describe pressure support is if you're lifting weights and you reach that failure point on a bench press and you can't quite get the bar off your chest. Imagine that's the patient that's intubated with an endotracheal tube in their airway. They're struggling that little bit. It's effort. Well, if you have a spotter behind you when you're lifting weights and they help get that bar off your chest and get it going, you're able to do that last bench press. That's kind of what each breath is doing. It's giving you that little assist so that it's not quite so hard to breathe through that restricted orifice of a endotracheal tube. I'll talk a little bit about the assist control mode of ventilation. You usually set a minimum breath rate, and ideal is in the 10 to 12 range. It can be as low as 8. You want to set a target tidal volume. What's considered a safe tidal volume in this day and age is roughly 6 to 8 milliliters per kilogram. You do not want to set it as years ago we used to do 10 to 15 milliliters per kilogram, and that causes ventilator-acquired lung injury, or VLI. Very bad to overdistend and shear the alveoli on a continual basis like that. You also have a PEEP that you want to set, which is usually set at 5 and adjusted if the patient's PO2 is still low and their FiO2 is still high. You can up the PEEP to 10 or something like that. The patient can breathe above the minimum breath rate. The respiratory rate can be higher than the set rate, and every time the patient triggers a breath, the machine gives the preset volume. So even if they're breathing 30 times a minute, every single time, whatever the tidal volume is set at, that's what the patient is going to receive in assist control. So again, this is pretty important on assist control. This is considered full ventilation or full mechanical ventilation. Now the example set here is if the respiratory rate is set at 12 and the tidal volume at 500 and PEEP of 5, the patient is guaranteed at a minimum 12 breaths at a volume of 500 milliliters. When you multiply those two together, the breath rate and the volume, that gives you a minute ventilation. If the patient's respiratory rate, their actual rate is 20, that means the additional 8 respirations are patient triggered and all will be given at 500 milliliters. Pressure support does not exist in this mode because there is no spontaneous breathing. There's spontaneous trigger, but no actual spontaneous respirations in between the preset volume. SIMV mode, you want to typically dial in pressure support with that. SIMV mode, you set the respiratory rate and the volume set just as before, and then dial in some pressure support. Average pressure support is set at 10. And the patient receives the minimum breath rate. In the previous example, if they're set at a respiratory rate of 12 and a volume of 500, you get a minimum of 12 breaths at 500, just as an assist control. But if they're breathing at a rate of 20, those additional 8 breaths will be synchronized, mixed in, so they won't breath stack. And the patient can breathe at whatever volume they want to breathe at for those spontaneous breaths, those other 8 breaths. This is typically a weaning mode because you can dial back the mandatory breath rate. Starting at 12, you can dial it back and typically reduce it by 2. So you're down to a breath rate of 2, and then that's almost the same as breathing in a spontaneous mode. And then you can tell if the patient's going to make it or not and have a successful extubation. Kind of a rehash of the last slide, the SIMV and pressure support mode. Laid out the example here just as stated before. Respiratory rate at 12 and the tidal volume at 500, PEEP of 5, and pressure support of 10. Patients guaranteed 12 of those breaths at a volume of 500 milliliters. And if the patient's actual respiratory rate is 20, those remaining 8 breaths will be patient triggered, but mixed in. In other words, the machine will not give a machine breath immediately in a breath stacking fashion. It will calculate out over the course of a minute about how many seconds are in between each breath, and then it will deliver a machine breath. If the patient is just considered a spontaneous breath. This is a great mode because you can reduce the mandatory breath rate down to essentially 2 to where they're spontaneously breathing, and that can tell you whether or not a patient is able to be extubated. Pressure support ventilation, or PSV, this is a totally spontaneous breathing mode. All breaths are pressure supported. Typically, they start that at 10, like we discussed. But you can also reduce that to 5 or 0, and there's even a function on the 840 ventilators by Puritan Bennett called tube compensation, where it calculates the resistance in the inner lumen of the tube and only provides that level of support. So it's like they're breathing without being intubated at all. In pressure ventilation, there's no guarantee of any breath rate, and there's no guarantee of any volume. It is typically used as a weaning mode, and this is typically used for spontaneous breathing trials just before extubation. CPAP. CPAP has a couple of meanings. In the invasive side, it goes with that pressure support ventilation on the last slide. So PSV, CPAP, you dial in pressure support of 10 and say CPAP of 5. Now the CPAP we're getting ready to talk about is the non-invasive form. Simply put, continuous positive airway pressure equals PEEP, which is positive end expiratory pressure. CPAP itself is used primarily for sleep apnea in the home. The pressure is determined in the sleep lab is the amount of pressure it takes to overcome the soft tissues that relax during sleep. These tissues cause a blockage where the patient's trying to breathe, but an occluded airway prevents the airflow to the lungs. So they always have the effort to breathe, but there's an obstruction preventing the air from flowing to the lungs. Easily corrected, dial in, the appropriate level of CPAP, and it usually maintains an open airway throughout the night's sleep so that they're not suffering desaturation continuously all night long, waking up very fatigued, tired, with headaches, etc. PEEP, or positive end expiratory pressure. Like I said, most ventilators usually set it at 5 centimeters of water unless a need for more is determined. This is very important in preventing atelectasis, which is a collapsing of the alveoli. Basically equivalent to a balloon that you start to blow up. You're not actually inflating the balloon, but the stem of the balloon is taut and open. Increase in PEEP equals an increase in the mean airway pressure, which equals an increase in your end PO2. PEEP is used in recruitment maneuvers to increase lung aeration and otherwise collapsed or atelectatic lungs. In ARDS, for instance, you can utilize a recruitment maneuver. A couple different ways you can do it. Studies are still out there on what is the best method. PEEP of 40 centimeters of water for 40 seconds has been used, and that opens up and recruits all those collapsed areas of lung. The other one is sequential PEEP increases, where basically you can go to PEEP of 10 for 2 minutes, then the PEEP of 20 for 2 minutes, back down to PEEP of 10, then go to 30, back down to 10, and then go up to 40 centimeters of water for 2 minutes, and then you can level off and go back to normal conventional ventilation, or even go into bilevel ventilation to maintain those airways open. Let's talk about ventilator alarms. High pressure alarms. That's probably the most common alarm us clinicians often hear is the high pressure beeping with each breath. High pressure alarms can be as simple as a cough. And a good strong patient with pneumonia, or coughing secretions, you'll often get a high pressure alarm associated with a cough. However, everything is not as simple as a cough. This can also be caused from an occluded airway. There's secretions that get so thick that they can obstruct a tracheostomy tube or an ET tube. They can be a kinked tube or a cuff occlusion. They make some cuffs that are low pressure, high volume cuffs, which are very nice. However, if there's a lot of movement with the ET tube, it is possible that the cuff can actually bend over the opening of the ET tube, and that can occlude the cuff or occlude the airway. Also, because you're a patient, the patient could develop a spontaneous pneumothorax, pulmonary edema, go into bronchospasm, any decrease in compliance of the lungs, or any ventilator dysynchrony. If they're bucking the ventilator, as we call it, you'll get high pressure alarms fairly often. But the number one rule to remember is when in doubt, always disconnect from the machine, manually ventilate with a bag valve mask, and assess the lungs and the airway, listening for wheezing from bronchospasm, decreased breath sounds of a pneumothorax, crackles of pulmonary edema, etc., etc. So diagnosing why you're getting the high pressure alarm is of utmost importance. Another alarm that's often heard is the high respiratory rate. Typically that is due to anxiety. Oftentimes a patient that's awake and alert, so to speak, gets very anxious that they're intubated or they have a trach in and they're on a machine. Oftentimes they will have a respiratory rate that's up around 40. That's typically where the limit is set at. Other things that can trigger it out of the blue are just increase in pain. Same thing with the change in patient condition. If somebody got a pneumothorax, for instance, you're probably going to experience a high respiratory rate alarm and a high pressure alarm. That's where things can get tricky, and figuring out what's going on. That's why you always start at the patient, work your way back through the airway, the tubing, back to the ventilator. Typically, something that does not happen in transporting a patient too often because we use an HME or heat moisture exchanger. But up in the ICU, the heated wire circuits are used with like a humidifier. And if you fail to drain the water in the tubing, the condensation, that sloshing, everybody that's walked by an ICU ventilator and seen that water sloshing in the tubing, that can also trigger like the ventilator getting double or triple with each gurgling of the water, and that can cause a false high respiratory rate. Low pressure alarms or low volume alarms, oftentimes they go together. So you get getting two alarms when there's only one problem sometimes. It's usually due to loss of pressure in the system. The reasons for that can be you lost your airway. The patient rolled around and partially extubated or totally extubated, but yet it's still in the mouth, going down the airway, but is not a seal inside the trachea where the lungs are. Another reason for this could be just simply a cuff leak. If the cuff gets deflated and the air is escaping around the tube, not necessarily going in the lungs, the ventilator will sense that and trigger off a low volume or low pressure alarm. The apnea alarm, same thing. Loss of airway, extubation, not going to be sensing the breath volumes and the rate and all that good stuff, and will create an apnea alarm. Another reason for this could be a respiratory arrest. Typically, you only see this not in your assist control mode or SIMB mode, but in pressure support ventilation. It's very important to set your apnea parameters. So if the patient fails to breathe for 20 seconds or 30 seconds, the ventilators will kick into assist control mode as a backup so that the patient basically cannot die on the ventilator. Yes, they will desaturate during that arrest period. Typically, they're set at 20 seconds, and then it'll kick back into full ventilation mode, which is, just control of 12 and a volume appropriate for the patient, 500, 400, somewhere in there. Oversedation is also another common cause of this apnea, but again, that mostly will occur in pressure support ventilation, where the patient's kind of in control of their own respiration, and when you're in assist control, the machine has that mandatory breath rate. So apnea does not happen, in those modes, only in the spontaneous breathing modes. Okay, when we talk about BiPAP, we're not talking about bi-level. We're talking about BiPAP. That is that trusty machine with the nasal mask, non-invasive ventilation only. There's an IPAP pressure and an EPAP pressure. Simply put, it's like pressure control ventilation. You set an inspiratory pressure, typically 12 to 15. You set an expiratory pressure, which is your PEEP, and that's typically set at 5. The difference between these two, if you subtract the IPAP from the EPAP, that is actually a calculation of the amount of pressure support that you're giving the patient. Obviously, the inspiratory pressure must always be greater than the expiratory pressure. If they were dialed in the same, say 6 and 6, that's simply CPAP of 6. There must be 2 separate pressures in order to be on BiPAP. BiPAP is used for a variety of things, from pulmonary edema and congestive heart failure. Provides enough airway pressure down to the alveoli to actually blow some of the fluid back out of the lungs, back into the systemic system. It helps prevent intubation by a patient with a high CO2 and a low pH. It's helping them overcome the work of breathing. And when it's worn for a period of 4 to 5 hours, it can greatly help correct a blood gas that's bad. Years ago, we used to intubate for. So BiPAP is a very handy thing. It can also be used in the home, similar to a CPAP, for somebody that's on extremely high CPAP pressures to clear their sleep apnea. You can basically use that high pressure on the IPAP end and reduce it a little bit so they can exhale. There's a couple different applications for a BiPAP, but that is a handy machine, but the patients seem to not like it very much because it's pretty uncomfortable to have your entire face enclosed in a mask and have pressure coming at you. The best analogy I can give you of being on a BiPAP is it's like riding in a convertible with your head hanging out the window. A little harder to breathe back out. The BiPAP uses, again, used to prevent intubation and respiratory failure patients, used in congestive heart failure and pulmonary edema exacerbations. Positive pressure created by BiPAP pushes fluid out of the alveoli back into the systemic system. Typical start settings these days are IPAP 12, EPAP 5, and then you can titrate it as need be. The titration part is just like a ventilator. Increasing your IPAP increases the pressure support and in turn increases your tidal volumes. Increasing the EPAP is equivalent to increasing the PEEP and your mean airway pressure, which, as we learned from before, increases your PO2. Pressure control ventilation. Pressure control can be used the same as assist control and SIMB. It's much like the BiPAP. Pressure control sets a pressure to achieve on inspiration. You don't set a volume, you simply set the pressure. However, when you figure out what's going on with your patient pressure usually equals a volume of some sort. So if you set a patient's pressure 20 or 25, usually you'll get a fairly consistent volume back, whether that be 200 or 300 or whatnot. And a little trickier to watch your patient for changes though, because if you start dropping volumes at that pressure, you got to figure out why. Most people use volume control, but pressure control is pretty common. The volume delivered is dependent on the lung condition, and it can change from breath to breath. There's no volume guarantee. To increase the volume, you must increase the pressure. It's typically used to protect the lungs from pressure-related injury or VLI. Okay, different from BiPAP is bi-level ventilation. Going back to that Puritan Bennett 840 ventilator, bi-level is two pressures set on an intubated patient, just like BiPAP. It's a fully spontaneous breathing mode. It alternates between a high pressure, which is P high, and a low pressure, P low. You set the pressure support so as they're spontaneously breathing, they get pressure support with each of those breaths, but they do it all from the P high mainly. You're able to set how much time they're at the high pressure and how much time they're at the low pressure. Typically, they're much longer at the P high than the P low. The P low is considered the release phase whereby CO2 is expelled, and it's typically very short, either half second to 1 second, compared to even up to 6 to 8 seconds at the P high. This is typically a mode used in ARDS to ventilate difficult patients experiencing massive atelectasis. I hope you enjoyed the presentation. I hope it was helpful. Any questions, you can always get a hold of me. I reside at Western Ridge most of the time, and Jennifer Seckel knows how to get a hold of me if there's anything else more specific pertaining to your ventilator or your modes or situations that you encounter. Thank you very much. I appreciate it.